Welcome to another episode from the Veterinary Medicine Digest. Today, we are undertaking a comprehensive and rigorous investigation into the sophisticated world of intracranial dynamics, specifically examining the physiological disturbances that occur when the rigid architecture of the skull is compromised. Our primary focus today is a landmark study regarding the effects of a parietal bone defect on the distribution of fluid pressure within the central nervous system of cats across various body positions. To appreciate the nuance of these findings, we must first establish a robust conceptual framework by reviewing the historical evolution of our understanding of the head as a biological container. For over 2 centuries, the medical and veterinary communities have relied upon the Monro-Kelly doctrine to explain the relationship between the volume and the pressure of the brain. This doctrine, which was refined by researchers such as Alexander Monro Secundus and George Kelly, posits that the adult skull is a firm and inflexible structure that effectively isolates its interior from external mechanical influences. Within this rigid fortress, there are 3 nearly incompressible components: the brain tissue itself, the circulating blood, and the cerebrospinal fluid. Because the total volume within the cranium must remain constant, the doctrine dictates that any increase in one component must be precisely compensated for by a corresponding decrease in another. If these compensatory mechanisms, such as the displacement of cerebrospinal fluid into the spinal compartment, are exhausted, the pressure inside the skull, known as intracranial pressure, will rise exponentially. In the modern clinical setting, this foundational principle remains the theoretical basis for managing life-threatening refractory intracranial hypertension. When non-invasive measures fail to control soaring intracranial pressure, surgeons often perform a procedure known as a decompressive craniectomy. By surgically removing a significant portion of the calcareal bone and opening the underlying thick membrane called the dura mater, the surgeon converts the closed cranium into a partially open system. This allows the swollen brain to expand outward, which can rapidly and substantially lower intracranial pressure and improve the chances of survival for patients suffering from severe brain trauma or malignant cerebral edema. Large trials, such as the randomized evaluation of surgery with craniectomy for uncontrollable elevation of intracranial pressure, have demonstrated that this intervention can significantly reduce mortality. However, the successful resolution of the initial pressure crisis is often just the beginning of a new set of physiological challenges for the survivor. A significant number of patients develop a baffling delayed neurological decline that can no longer be explained by elevated pressure. This clinical phenomenon is known as the syndrome of the trephined or the sinking skin flap syndrome. The syndrome of the trephined manifests through a spectrum of motor, cognitive, and sensory deficits that typically emerge weeks or months after the initial surgery. Patients may suffer from severe headaches, dizziness, language deficits, and a general failure to progress in their rehabilitation. A hallmark of this condition is its orthostatic nature, where neurological symptoms often worsen when the patient is in an upright position and improve significantly when they lie flat. Radiographic evaluations frequently reveal a visible depression of the scalp at the site of the bone defect, known as the sinking skin flap sign. In some extreme cases, the difference in pressure between the atmosphere and the intracranial space can even cause the brain structures to shift away from the defect, a dangerous condition referred to as paradoxical herniation. The fact that these neurological symptoms can be dramatically reversed by a cranioplasty, the surgical replacement of the missing bone flap, suggests that the integrity of the bony skull provides a critical physiological function that goes far beyond simple mechanical protection. Despite the recognition of this syndrome for nearly a century, the precise cause and effect mechanisms remain poorly understood. Theories have ranged from the direct transmission of atmospheric pressure onto the brain tissue to the disruption of cerebral blood flow and impaired venous return. To gain a deeper understanding of these neurofluid dynamics, researchers turned to animal models, specifically anesthetized adult cats. The feline model is particularly valuable for this research because the responses of their cerebrospinal fluid pressure to changes in body position have been well documented in previous physiological studies. In the core study we are reviewing, researchers performed a standardized parietal craniectomy on 8 adult cats and simultaneously measured the pressure within the lateral ventricle of the brain and the lumbar subarachnoid space of the spine. The animals were secured to a rigid board and moved through a protocol of 5 standard body positions: horizontal at 0 degrees, head up at 45, 90 degrees, and head down at 225 and 270 degrees. The results of this feline study provide a fascinating glimpse into how a skull defect alters the fundamental pressure landscape of the central nervous system. In the horizontal position, the pressures in the brain and the spine were nearly identical, both measuring approximately 16 centimeters of water. When the cats were tilted into the 90-degree head-up position, a significant pressure gradient formed across the craniospinal axis. The pressure in the brain fell to a subatmospheric level of negative 1.5 centimeters of water, while the pressure in the lower spine rose to 31.4 centimeters of water. While this reciprocal relationship, low pressure in the head and high pressure in the spine, is characteristic of any intact system during verticalization, absolute values in the craniectomized cats were remarkably different from those of cats with intact skulls. When the researchers compared their data to previously published measurements of healthy cats with intact skulls in the same 90-degree upright position, they discovered that the cats with a craniectomy had significantly higher intracranial pressure. In the cats with the rigid intact skulls, the pressure in the lateral ventricle dropped much further into the negative range, reaching nearly negative 4 centimeters of water. This finding indicates that even when the overall intracranial pressure is within a normal range, the presence of the bone defect itself forces the baseline pressure within the head to stay higher than it would naturally be in an intact system. This has profound implications for our understanding of the syndrome of the trephined. It suggests that for a patient missing a portion of their skull, the brain is chronically subjected to an environment of higher absolute pressure whenever they are in an upright or seated position. Why does this shift in baseline pressure occur? The researchers proposed 2 primary mechanisms. First, the influence of atmospheric pressure is paramount. In an intact skull, the brain is shielded from the weight of the surrounding air. However, after a decompressive craniectomy, the atmosphere can exert its force directly on the intracranial contents through the soft, compliant tissue of the scalp and the dura mater. When a subject is upright, gravity naturally pulls the cerebrospinal fluid downward toward the spine, creating a negative pressure or suction effect within the head. In a craniectomized subject, the atmosphere effectively pushes back against this suction, dampening the development of negative pressure and keeping the intracranial level closer to the atmospheric zero. This essentially means that the atmosphere is pressing on the brain, preventing the natural pressure drop that occurs during posture changes. The second proposed mechanism involves a significant shift in the volume of the cerebrospinal fluid itself. Under the combined forces of gravity and atmospheric pressure, a larger volume of fluid may be pushed from the cranial compartment into the spinal subarachnoid space. This increased volume in the spine may then cause a cranial shift of the hydrostatically indifferent point. This indifferent point is defined as the location in the body where the fluid pressure remains unchanged, regardless of whether the subject is horizontal or vertical. If this point shifts toward the head, it results in higher overall pressures throughout the cranial cavity. The feline study confirmed that while the craniectomy did not interfere with the mechanism that generates posture-dependent pressure gradients, it fundamentally modulated the absolute level of pressure the brain must endure. This persistent alteration in pressure is not merely a numerical curiosity. It has tangible and detrimental effects on the health of the brain tissue. To understand the microscopic consequences of these shifts, we must examine recent research regarding the glymphatic system, which is the brain's specialized waste clearance pathway. The glymphatic system facilitates the movement of cerebrospinal fluid into the brain tissue along the spaces surrounding the arteries, where it washes away metabolic waste products before exiting through the spaces surrounding the veins. This vital circulation depends on the rhythmic pulsations of the brain's penetrating arteries to provide the driving force for the fluid flow. Crucially, for these arterial pulsations to be effective, they require a closed and rigid cranial compartment to create the necessary resistance and motile force. In groundbreaking murine models, researchers have demonstrated that simply opening the skull causes an immediate and significant reduction in the pulsatility of these penetrating arteries. This reduction in pulsatility leads to a chronic impairment of glymphatic flow throughout the brain. When the air hits the brain, the system's ability to clear toxins is compromised, leading to the accumulation of metabolic byproducts and the triggering of a neuroinflammatory response. This inflammation is evidenced by the activation of reactive astrocytes and microglia, which are specialized cells that respond to brain stress and injury. Over time, this glymphatic stagnation and subsequent inflammation lead to measurable deficits in motor coordination and cognitive function. Much like the feline pressure studies, these mouse studies showed that the reestablishment of a closed cranial compartment through cranioplasty could accelerate the recovery of glymphatic flow and normalize the inflammatory response. The synthesis of this research provides a powerful explanatory framework for why patients with skull defects are so susceptible to neurological failure. Every time a patient with a decompressive craniectomy sits up to begin their physical therapy, the absolute pressure within their head rises to an abnormal level. This pressure shift disturbs the delicate gradient between the blood capillaries, the interstitial fluid between the brain cells, and the cerebrospinal fluid. This disruption likely impairs local blood flow and cerebral metabolism, contributing to the psychomotor slowing and decreased animation often observed in these individuals. The impairment of the glymphatic system's waste clearance function further exacerbates the problem, leading to a state of chronic brain stress. The clinical implications of these findings are substantial for both veterinary and human medicine. They suggest that the syndrome of the trephined may be much more frequent than previously reported. In a prospective longitudinal cohort study, researchers found that 65% of patients with large craniectomies developed the syndrome. Many of these cases were insidious, presenting not as a sudden decline, but as a subtle failure to progress during rehabilitation. This has led to the classification of a priori and a posteriori forms of the syndrome, where the latter is only identified after the patient shows a rapid and measurable neurological improvement following a cranioplasty. The research strongly argues that clinicians should maintain a high degree of suspicion for this syndrome in any patient who has undergone a large skull removal and has reached a plateau in their recovery. Furthermore, the timing of the cranioplasty emerges as a critical factor in determining the ultimate neurological outcome. The prospective data shows an association between improved neurological recovery and shorter delays to the bone replacement surgery. For every additional day that the cranioplasty is delayed, the odds of a significant neurological improvement decrease by 4%. In fact, the studies suggest a potential window of opportunity to perform the cranial repair as soon as the initial brain swelling has subsided, potentially as early as 2 weeks after the original craniectomy. Waiting for a fixed arbitrary period of 3 to 6 months may inadvertently subject the patient to prolonged periods of abnormal pressure and glymphatic dysfunction, which could lead to irreversible neurological deficits. The feline study specifically highlights that we can no longer view the brain in a static state. The intracranial environment is a dynamic system that is constantly interacting with the forces of gravity and the weight of the atmosphere. The bony cranium is not just a shield, it is a vital regulator of the pressure and flow dynamics that keep the central nervous system healthy. For the veterinary community, this research emphasizes the need for vigilant post-operative monitoring of animals that have undergone cranial procedures. We must look for subtle signs of discomfort, cognitive changes, or postural distress that might indicate a disturbance in these delicate fluid gradients. As we conclude this deep dive, the message is clear. The removal of a portion of the skull fundamentally changes the physics of the brain. While the decompressive craniectomy remains a vital tool for saving lives in the face of uncontrollable pressure, it creates a temporary physiological state that is fraught with long-term risks. By understanding how body position and atmospheric pressure interact to alter the absolute level of intracranial pressure and impair the brain's waste clearance systems, we can better tailor our treatments to each individual patient. Tailoring the timing of the cranioplasty to the resolution of edema and the emergence of neurological plateaus could be the key to preventing the syndrome of the trephined and ensuring the best possible quality of life for our patients. We must continue to bridge the gap between these sophisticated animal models and our clinical practice to keep pushing the boundaries of what is possible in neurorehabilitation. Thank you for listening. The titles for the referenced papers are in the video description. From VetMed Digest, where we keep minds inspired, hearts light, and tails wagging.